Hey there. Ready for another deep dive?
Let's do it.
Okay, so today we're tackling a really focused topic based on the revision notes you've got.
Yeah.
Actinic keratosis, AKs.
Yep. And the goal here is pretty clear, right? We want to take these notes, which look nicely structured, by the way, and really help you cement that information. Make it high yield, easy to recall.
Exactly. Turning revision points into, a proper understanding. We'll stick strictly to what's in these sources, covering the whole spectrum.
From the basic definition, what causes them, who gets them, what's actually happening in the skin, all the way through to management and what happens long term.
Right, so think of this less like us reading at you and more like we're working through the notes with you, trying to make it stick. Sound good?
Perfect. Let's jump in definition first. According to your source material, what are we actually talking about with AKs?
Okay, so the core definition here is
Mm-hmm.
they're precancerous skin lesions. Big point right there.
Yeah.
And they come from prolonged sun exposure. You see them, or rather feel them often, as rough, scaly patches, usually on those bits of skin that have seen a lot of sun.
And the notes mention other names too. Solar keratosis, senile keratosis, same thing.
Yeah, exactly. But that precancerous word, that seems to be the absolute key takeaway.
It really is. Because it means they have the potential, not a guarantee, but the potential, to develop into squamous cell carcinoma, SCC, a type of skin cancer.
So not definitely cancer, but could become cancer.
Precisely. Your notes say they can resolve on their own or just stay as they are for ages, but that potential is why they're clinically significant. The name itself, actinic keratosis, apparently coined back in the 50s, literally means a thickened, scaly growth caused by sunlight. Actinic for light, keratosis for thickening.
Makes sense. So yeah, a physical sign of sun damage. The notes highlight fair-skinned people with lots of sun exposure, including tanning beds, they point out.
Good point. Yes, any significant UV source counts. And they are, according to the notes, the most common skin lesion out there that carries this malignant potential from UV. They get compared to Bowen's disease briefly,
Oh, yeah.
which is also like a very early skin cancer, but the notes suggest AKs are maybe generally less likely to progress than Bowen's.
Okay, so for you listening, understanding this definition is job number one, right? It tells you what you're looking for, rough, scaly, sun-exposed areas, and why it matters that potential link to cancer.
Couldn't say it better. All right, we know what they are. What about the why, the cause, or etiology, as the notes put it?
This part in the notes is super straightforward. The main cause, it's just chronic exposure to ultraviolet radiation, UV, mostly from the sun.
Simple as that. It's that long-term cumulative damage, decades of it.
Right. Which leads nicely into the next bit. Who's most likely to get them? Are some people more prone than others, even with sun exposure?
Right.
The risk factors.
Yeah, good question. And the notes lay these out clearly. It's helpful to think, okay, who's most vulnerable to those long-term sun effects? The list includes fair skin, makes sense, less natural protection. Older age, simply more time for that sun damage to add up.
Right. Cumulative effect.
Exactly. Then there's a history of excessive sun exposure, obvious link there. Living in sunny climates, so more intense, more frequent UV.
Like the Australia statistic we'll get to later.
Precisely. Also, a history of sunburns, especially blistering ones, they signal significant past damage. And finally, having a weakened immune system.
Why the immune system?
Well, the body's less able to repair that DNA damage we talked about, or to clear out abnormal cells before they become a problem.
Got it. So if you're trying to remember that list for revision, maybe group them. Like your natural features, fair skin, getting older, then your exposure history, lots of sun, bad burn, sunny place, and then your body's defense of the immune system.
That's a great way to frame it. Understanding these risk factors helps you, identify who needs to be extra careful with sun protection and skin checks.
Okay, let's go a bit deeper now. Pathophysiology. What's actually happening in the skin cells when an AK develops?
So it all kicks off with that UV radiation hitting the skin cells. Your notes explain this damages the DNA inside the cell.
The cell's blueprint, essentially.
Exactly. Think of it like getting errors in the code. The UV light corrupts that blueprint.
Okay.
And this DNA damage messes up the normal cell growth cycle. It leads to abnormal cells starting to grow and multiply when they shouldn't. The notes mention specific UV-induced gene mutations are involved.
Uh-huh.
And interestingly, they also throw in that human papillomaviruses, HPVs, might sometimes play a role too, though UV is the main driver.
So scramble instructions lead to faulty cell production.
Pretty much. And under the microscope, histologically, your notes say these abnormal cells in an AK look quite similar to the cells you'd see in an actual squamous cell carcinoma.
Ah, showing that connection.
Yes, reflecting that they both arise from the same top layer of the skin, the epidermis. Now, what happens to these AKs? Your notes say there are a few possibilities.
Right. They don't all become cancer.
Correct. An AK might actually resolve spontaneously. The body just clears it up. Or it could just stay stable, unchanged for years. Or, the important one, it can progress to SCC.
And the notes are clear that AKs are seen as an early warning sign for SCC development.
Explicitly, they're considered part of that spectrum towards invasive cancer.
Wow. Okay, so that whole chain reaction sun damage, messed up DNA, abnormal growth, potential cancer, it really hammers home why sun protection is number one.
Yeah.
We stop the first domino from falling.
Absolutely. Prevent that initial DNA damage. Okay, now, you see a suspicious scaly patch. Could it be something else? Differential diagnosis. What conditions look similar to AKs?
Yeah, this is crucial. Your notes list a few key mimics. Top of the list, the ones you really don't want to miss, are actual skin cancers.
Yeah.
Squamous cell carcinoma, SCC, and basal cell carcinoma, BCC.
And how do the notes suggest you tell them apart from a simple AK?
The main clue given is change. SCCs and BCCs are more likely to show rapid growth, or signs of breaking down, like erosion or ulceration, becoming like a little sore. AKs tend to be slower, more stable.
Right. So speed of change and breakdown are red flags pointing potentially towards malignancy, not just the precancerous AK. What about seborrheic keratosis? They're super common too, those sort of stuck-on looking things.
Yeah, the notes differentiate these based on texture and the skin underneath. Seborrheic keratoses are described as having greasy crusts and sitting on a non-red base.
Okay.
Whereas AKs are rough and scaly like sandpaper and often have a red or pinkish base underneath.
Got it. So greasy versus rough. Normal skin color base versus red base. Good distinctions. What about Bowen's disease?
Your notes describe Bowen's as typically appearing as a large, well-defined plaque, kind of like a bigger, more outlined patch. AKs are usually smaller, often you have several, and their edges might be a bit less distinct.
Okay, a difference in size and outline. And the notes also mention a couple of others to keep in mind.
Yeah, a melanotic melanoma. That's a melanoma without the typical dark pigment, which can be tricky. And discoid lupus erythematosus, an autoimmune skin condition.
So really knowing those key differences from your source is key. Let's try a quick scenario based on the notes. You feel a rough patch on your forearm, feels like sandpaper, been there maybe 6 months, hasn't really changed. What's top of your list?
Based on the notes, sounds very much like an AK. Grade 1 or 2 maybe.
Okay. Now, same area, but you only noticed it a month ago, and it's definitely bigger now, maybe feels a bit thicker, and there's a little crusty bit in the middle that keeps coming off.
Okay, now the rapid growth and that crusty bit, the ulceration perhaps, that would make me think more towards SCC or BCC, needing a proper look quickly.
Exactly. So focusing on those differentiators, your notes give you growth rate, ulceration, texture, greasy versus rough, base color, outline. That's how you start to tell these things apart. And it shows why getting a professional opinion is vital.
Definitely. Not everything scaly is an AK.
Right. Let's zoom out again. Epidemiology. How common are AKs and who gets them most often, according to the source material?
Okay, epidemiology. Notes say they're very common, especially in those risk groups. Fair-skinned people with a lot of sun exposure. And the prevalence really ramps up with age.
Makes sense. That cumulative effect again, both genders.
Both, yes, but the notes mention often more common in men. The thinking there is generally more lifetime outdoor exposure, maybe through work or hobbies.
Yeah, that's often cited. Any specific numbers in the notes?
Yes.
Okay.
In the UK, they say it's rare below age 45, but jumps to like 19-24% of people over 60.
Okay, nearly a quarter of older adults in the UK.
But then compare that to Australia. Notes say 40-60% of Caucasians over 40 have AKs there.
Wow, that really shows the impact of climate and UV levels, doesn't it?
Absolutely stark difference. It really drives home how common these markers of sun damage are, especially as people get older or live in sunnier places.
And the final key point your notes make about epidemiology, it's not just about the AKs themselves, is it?
No. It's that having AKs signifies widespread sun damage. And crucially, it means you're at a higher risk of all skin malignancies overall, not just SCC developing from that specific AK.
That's such an important concept. AKs are like a warning flag for the whole skin. We'll definitely come back to that. But first, let's get practical. Clinical presentation. What do AKs actually look and feel like on the skin?
Okay, the description in the notes: rough, scaly patches, usually on those sun-exposed areas, face, scalps, especially bald scalps, ears, forearms, back of the hands are all listed.
The classic sun trap areas.
Exactly. They're described as small lesions, can be crusty or just scaly, and the color can vary a bit.
And that texture, like sandpaper?
Yes. The notes explicitly mention a sandpaper-like texture for the moderate grade, and a really key point is that they are often multiple. The source uses the term field change.
Ah, yes, field change. What does that mean exactly?
It refers to a larger area of skin that has multiple AKs, often close together, sitting on a background of other sun damage signs, like thinning skin or broken blood vessels.
So not just one isolated spot, but a whole zone affected. And diagnosis is usually clinical.
Correct. The notes say diagnosis is typically made just by a doctor looking and feeling the lesion. Considering the patient's history of sun exposure, it's usually quite characteristic.
Okay. And your notes provide a grading system. That sounds useful for understanding severity.
Yes, really helpful. It goes, Grade 1, mild. These are subtle, often better felt than seen. Slightly rough, maybe pink or grayish, quite flat. Grade 2, moderate. More obvious now, you can easily see and feel them. Red patches, definite sandpaper texture. Grade 3, severe. These are quite thick, maybe raised. Hyperkeratotic is the term used. Very obvious. The notes say these can look quite like an early SEC already.
And field change sits alongside that grading.
Yeah, field change isn't a grade of a single lesion, but describes that whole area having confluent lesions, which could be of any grade, on that sun-damaged background.
Okay, that makes sense. How do they evolve over time on the skin?
Notes say they typically start small and rough, then might get bigger, maybe redder, more obviously scaly. Sometimes multiple ones can merge together. There are variations mentioned too. Some can be pigmented. Some look a bit like another condition called lichen planus. Some get really thick and warty, that hyperkeratosis again.
Yeah.
And things like immune suppression or more UV can make them worse.
And the all-important risk of progression to cancer. Any numbers attached?
Yes. The notes give a figure. Around 10% might become malignant SCC within 10 years. And it specifically flags up lesions that are more erythematous, red, and elevated or thickened as being higher risk. Sometimes removing one is partly just to biopsy it and check that risk.
Right. So this gives you, the listener, a really good sense of what you're looking for, that specific rough feel, the locations, the fact they often come in groups, the different grades of thickness, and that progression risk really underlines why they need attention.
Definitely. So say you find something suspicious, you go to the doctor. What investigations happen next, according to your notes?
Well, the notes reiterate that diagnosis is usually clinical. Just looking and feeling by someone experienced is often enough.
So you don't always need tests.
Not always. A biopsy isn't standard for every single suspected AK. However, the notes say a skin biopsy might be done under certain circumstances.
Such as?
If there's a strong suspicion it might already be an SCC, maybe it's growing fast, ulcerated really thick like that grade 3, or if the diagnosis just isn't certain, then they'll want a tissue sample to look at under the microscope.
Okay, so biopsy for high suspicion or uncertainty, and the clinical grading we just talked about is part of that initial assessment process too.
Exactly. It helps decide the level of concern. Your notes also outline the referral pathways. Many straightforward AKs, especially milder ones, can be managed perfectly well in primary care, perhaps by a GP with a special interest, GPWSI.
But what triggers a referral?
If features suggest SCC, those grade 3 signs, rapid change, ulceration, G-mins, the notes say refer urgently on the 2-week suspected cancer pathway. That's the fast track.
Okay. Urgent referral for cancer suspicion.
Right.
Any other reasons for non-urgent referral?
Yes, the notes mention referring non-urgently if the diagnosis is unclear, if the person has really extensive sun damage, severe field change, if they're immunosuppressed because their risk is higher, or if AKs show up in someone very young, which is unusual and needs looking into.
Got it. So often clinical diagnosis is fine, but specific red flags or patient factors mean a quicker or more specialist assessment is needed. Your notes map that out well.
Right. So let's say the diagnosis is made. It's an AK. How are they managed? What are the treatment options listed in the source?
First principle, the notes state. Treat AKs because of the cancer risk. It's not just cosmetic.
Fundamental point. And the choice of treatment depends on various factors.
Yes, things like the grade, the location, how many lesions there are, if there's field change, the size of the area involved.
Makes sense. What are the main treatment types listed for multiple AKs or field change?
For those situations, the notes list topical therapies, creams or gels. Specific examples given are 5-fluorosil, 5-FU, imiquimod, and diclofenac sodium gel.
Right, those are common ones, and they require applying them for a while?
Yes, usually daily for several weeks. And the notes make a really important point about patient counseling for these topicals.
Ah, yes. What should patients expect?
They must be warned about the expected skin inflammation. These treatments work by basically attacking the abnormal cells, which causes a significant reaction. Redness, soreness, crusting, peeling. It can look quite dramatic and feel uncomfortable.
But that reaction is actually a sign it's working, right?
Exactly. It means the drug is targeting those damaged cells. So if your notes were a patient leaflet, the big bold text would say, expect inflammation.
Crucial piece of advice. What about treatments for individual lesions or maybe smaller areas?
For those, procedures are more common. The notes list cryotherapy, freezing them off with liquid nitrogen. Very common. Also curettage, which is scraping the lesion off, sometimes followed by cautery. And photodynamic therapy, PDT, is mentioned too.
PDT involves applying a cream that makes the cells light sensitive, then shining a special light on them.
Right, and surgical excision, cutting it out, is also listed as an option, maybe for thicker lesions or where you definitely want a biopsy sample.
Okay, so a range of creams and procedures. What about non-prescription advice, the patient education part?
Super important. Your notes list key things. Limit sun exposure and use sun protection. Hats, clothing, high SPF sunscreen. This is prevention for the future. Use emollients, moisturizers, for comfort, as sun-damaged skin is often dry. Report any changes, new spots, or changes in existing ones. Vigilance is key.
And explaining the significance.
Yes. Explain that the AK itself is a marker for increased skin cancer risk overall. And finally, always do a full skin exam on the patient, because if they have AKs, they might have other worrying lesions elsewhere they haven't noticed.
Excellent point. So management is definitely not just about zapping the spot you see. It's about the bigger picture of skin health and future prevention.
Absolutely. Which brings us to the final section, prognosis and complications, long-term outlook.
Okay. Main complication we've already flagged.
The potential progression to SCC. That's the big one.
Right. What about the prognosis for the AKs themselves?
Notes give a mixed picture here. They say many AKs can actually regress spontaneously. They just vanish.
Oh, really?
Yeah. But there's a high risk of recurrence, the same one coming back after treatment, or, more likely, new lesions developing elsewhere, because the underlying sun damage across the skin is still there.
Ah, so treating one doesn't cure the sun damage.
Exactly. It's like fixing one pothole when the whole road is crumbling. Progression to SCC when it happens is usually slow, and the probability for any single AK isn't massive. But if someone has dozens of AKs,
that risk adds up across the board. So the notes circle back to prevention.
Constantly. Sun avoidance and sunscreen use are key preventative strategies mentioned again here.
And patient vigilance.
Absolutely essential. Self-monitoring for changes and seeking medical advice promptly if anything looks different. New lesions or changes in size, shape, color, or texture of existing ones.
And that final, really crucial takeaway point the notes make under prognosis.
It echoes the epidemiology point. AKs are more than just lesions. They're a biological marker of significant sun damage. Having them means you, the patient, are at a greater overall risk of developing any skin cancer, BCC, SCC, even melanoma later on.
That is such a powerful concluding thought from the source material. It really shifts the perspective from just treating a spot to managing long-term risk.
It does. Even if an AK is treated successfully or goes away on its own, the fact it was there signals that underlying damage. It means lifelong vigilance with sun protection and skin checks is needed.
A lifelong relationship with your skin's history, as you said earlier.
Well, we've certainly worked through these notes. From the definition precancerous, sun-caused rough patches, through the causes, risks, the science underneath, what they look like, what else they could be.
How common they are, how doctors investigate and grade them, the different treatment approaches, and finally the long-term picture and what they signify.
I think the absolute key messages distilled from your source are AKs equals sun damage markers. They can become cancer, so need attention. But many don't. Treatment is available. Prevention is paramount. And they signal a higher overall skin cancer risk.
Nicely summarized.
And thinking about that very last point from the notes, AK signaling higher risk for all skin cancers, here's a final thought for you to consider based on that. If AKs are a sign of widespread damage, what does that really mean for how thoroughly you need to check all your skin regularly, not just the bits where you've had AKs before, even years later? Something to mull over.
Definitely. Understanding this topic, using your notes as a foundation, is really valuable, whether it's for revision or just general health knowledge.
Absolutely. And if you are revising and want more practice, remember you can find extra resources and questions over at MSRA.com.
That's right. And for free practice questions to test yourself on topics like AKs and many others, check out MSRA.com. Great way to consolidate your learning.
Okay, that wraps up our deep dive into actinic keratoses, all based on the material you provided. Thanks for bringing your notes to the table.
Always a pleasure.
Bring us your next set of sources, and we'll dive in again soon.